Welcome to this series of videos on communicating with chronic pain patients. This is Module 9, Shared Decision-Making and Goal Setting. What matters to you? Imagine a patient with chronic low back pain comes to see you. You complete your assessment and say, here's what I'd like you to do. Walk 30 minutes a day, perform these 6 exercises 3 times a week, and come see me twice a week. The patient nods. Okay? We might walk away thinking, great, we have a plan, but do we? There's an important question we haven't asked. What does the patient want? Because there's a big difference between creating a treatment plan for a patient and creating a treatment plan with a patient. And that's where shared decision-making comes in. Shared decision-making is exactly what it sounds like. The healthcare provider brings clinical expertise. The patient brings something equally important, expertise about their own life, their priorities, their experiences, their preferences, their concerns, their values, and their goals. We bring those two forms of expertise together to develop a plan. This is especially important in chronic pain because there often isn't one single correct treatment. There may be multiple reasonable options: exercise, education, behavioral approaches, medication, lifestyle changes, different combinations of interventions. The question isn't always, what's the best treatment? Sometimes the better question is, what's the best treatment for this particular person? There's a simple question that can completely change a chronic pain encounter. What would you like to be able to do that pain is currently preventing you from doing? Listen to how different that is from, what number is your pain today? Pain intensity is important, but it doesn't necessarily tell us what the patient wants their life to look like. One patient with knee pain might say, I want to be able to walk upstairs without pain. Another might say, I want to get back to playing golf. Another might say, I just want to be able to get down on the floor and play with my grandchildren. Same diagnosis, potentially very different goals. Research involving people with chronic pain has actually asked patients what they want providers to ask them. Patients described wanting clinicians to ask about the impact pain has on their daily activities, relationships, work, goals, and even their dreams. So perhaps one of our most powerful assessment tools isn't another physical test. It's asking, what do you miss doing? Here's another challenge. Ask someone with chronic pain what their goal is, and they may say, I want zero pain. That's understandable. But what happens if eliminating pain completely isn't a realistic short-term goal? We don't want to take away hope, but we also don't want someone's entire definition of success to depend on a pain score reaching zero, so we can broaden the conversation. You might say, I absolutely understand wanting the pain to go away. While we're working on your symptoms, can we also identify something the pain has taken away from you that you'd like to start getting back? Maybe the patient says, I'd like to walk my dog again. Great. Now we have another measure of success. Instead of only asking, did your pain decrease? We can also ask, are you doing more of what matters to you? That's a very different way of measuring progress. Shared decision-making also means giving patients meaningful choices when choices exist. Imagine 2 reasonable treatment approaches. Instead of saying, here's what we're going to do, try, there are a couple of reasonable ways we could approach this. Let me explain the advantages and disadvantages of each, and then I'd like to hear what makes the most sense to you. Notice what that communicates. Your opinion matters. But there's an important distinction. Shared decision-making doesn't mean you're the patient. You decide everything. Patients come to us because they want our expertise. If I simply list 5 treatments and say, which one do you want? I haven't necessarily helped them make a decision. Our job is to explain the options clearly, discuss the likely benefits, discuss the limitations, explore the patient's preferences, and then arrive at a decision together. Some clinicians worry that patient-centered care means simply agreeing with whatever the patient wants. It doesn't. Suppose a patient requests a treatment you don't believe is appropriate. You can still say, I understand why that option appeals to you. Can I explain why I have some concerns about it and talk through some alternatives? That's still shared decision-making. The clinician doesn't disappear from the decision, and neither does the patient. Recent research emphasizes exactly this point. A 2026 review of shared decision-making in chronic pain describes it not as one conversation or one decision, but as an ongoing process. Patient preferences can change, symptoms can change, goals can change, and the treatment plan may need to change with them. The plan we create today isn't a contract. It's something we continue to evaluate together. Once we understand what matters to the patient, we can create goals around it. But be careful. Healthcare goals can sometimes become very clinical. Improve lumbar flexion by 10 degrees. Improve quadriceps strength to 4 plus out of 5. Those measures may matter to us, but they probably aren't why the patient came to see us. Instead, connect those clinical goals to something meaningful. Maybe the patient's goal is, I want to attend my daughter's soccer games. Now we can work backward. What prevents that? I can't sit on the bleachers for an hour? Great. Now we have something specific to work toward. Perhaps the first goal isn't sitting through an entire game. Maybe it's sit for 15 minutes comfortably, then 25, then 40. Eventually, maybe they attend part of a game. That's meaningful progress. And notice what we've done. We've connected rehabilitation to the patient's life. There's another mistake we make with goal setting. We sometimes make the first goal too big. Patient, I want to start hiking again. Provider, great. Start walking 30 minutes every day. But perhaps the patient hasn't walked more than 5 minutes in months. Instead, ask, what's a first step that feels realistic to you? Maybe the patient says, I could walk to the end of my street and back. Perfect. We can always progress later. Remember something from motivational interviewing. The best plan isn't necessarily the most ambitious plan. It's the plan the patient is actually willing and able to begin. Here's one simple question I love. After agreeing on a goal, ask, on a scale from 0 to 10, how confident are you that you can actually do this? Suppose the patient says, 4. Don't respond, come on, you can do it. Instead, get curious. What would we need to change to make that a 7? Maybe walking 30 minutes feels impossible, but 10 minutes feels manageable. Now we have a better plan, because a perfect treatment plan that the patient doesn't follow isn't a perfect treatment plan. Research increasingly supports shared decision-making as an important component of pain care. A 2024 scoping review examines shared decision-making and collaborative care approaches in acute and chronic pain. The authors concluded that these approaches are promising, while also emphasizing that we still need more research on outcomes such as quality of life, patient satisfaction, and patient-provider communication. And broader research on shared decision-making has found benefits, particularly around the quality of the decision-making process. But we shouldn't oversell it. Shared decision-making isn't a treatment for chronic pain by itself. It doesn't replace good clinical reasoning. And simply asking a patient what they want doesn't guarantee better outcomes. Instead, think of shared decision-making as a way of making sure the treatment plan reflects both the evidence we bring as clinicians and the values and priorities the patient brings as a person. Here's a simple framework you can use tomorrow. Ask, offer, agree. First, ask, what matters most to you? What would you like to get back to doing? What concerns you about the different options? Then, offer. Explain the reasonable options. Share your expertise. Discuss benefits, limitations, and uncertainty in plain language. Then, agree. Develop a plan together. And before the patient leaves, ask, does this plan actually feel realistic to you? That final question matters, because sometimes patients agree with us simply because we're the healthcare provider. Agreement isn't necessarily commitment. Chronic pain can take away a tremendous amount of control. Patients may feel like their bodies control them, their symptoms control them, their appointments control them, and sometimes even healthcare providers control them. Shared decision-making gives some of that control back. So don't just ask, where does it hurt? Ask, what matters to you? Don't simply tell patients what they're going to do. Invite them into the decision, and don't measure success only by whether pain decreased. Ask whether the patient is beginning to reclaim the parts of life that pain has taken away. Because ultimately, our goal isn't simply to help patients achieve a better pain score. It's to help them build a better life, even while we're still working on the pain.